Welcome to AETCM, the emergency medicine channel. Now let us discuss about the second part of ECG, that is tachycardia, bradycardia and its management. Now we have already learned that the normal pulse rate in human being is 60 to 100 beats per minute, which is regular. If the heart rate is less than 60, some books have given 50. For practical purposes, we will take 60. Bradycardia means heart rate less than 60. Tachycardia means heart rate more than 100 beats per minute. There are multiple reasons for tachycardia and bradycardia. We will see the tachycardia first. It can be physiological because of anxiety, fear, pregnancy and all. Pathological, it can be due to fever, anemia, thyrotoxicosis and cardiac diseases like atrial fibrillation, SVT, VT and drugs like some of the drugs like atropine antagonist. Actually it is not beta agonist and atropine. So these drugs also can produce some amount of tachycardia. Many cough medications like phenylephrine, pseudoephedrine, all these things also can produce tachycardias. Bradycardia we will see afterwards. There are multiple reasons for that. Now sometimes we will get sinus tachycardia. Sinus tachycardia means you have a P wave, you have a PR interval, you have a QRS complex, RR interval is regular but the heart rate is fast. SVT means the SVT, I will draw like this. This is the ventricle, this is the ventricle, this is the atrium. SA node to AV node conduction is like this. If anything originating above the ventricle, it can be from the atria itself, anywhere in the atria or in the junction, that is the AV node, AV nodal re-entry tachycardia, or from the SA node to AV node, then there is a re-entry circuit. That circuit produces a circus of movement. That also can sometimes produce tachycardia. This is called as AV re-entry tachycardia. This is AV nodal re-entry tachycardia. This is AV re-entry tachycardia. Then atrial fibrillation, multiple focuses firing electricity, and that all produces QRS complexes. That is called as atrial fibrillation. So you can see here sinus tachycardia, atrial flutter, atrial fibrillation, multifocal atrial tachycardia. These are all things we have taken yesterday. AVRT, AVNRT. AVRT means AV re-entrant tachycardia. AV nodal re-entrant tachycardia is like this. AVRT is like this. Okay. Now SVT we have already discussed. It's a rhythm originated above the ventricle. So it can be here, or a AV nodal re-entry, or a AV re-entry. All these things can produce sometimes tachycardia. Re-entry means the current which is produced from the SA node will go to the AV node. Sometimes this will not, instead of going this side, this will loop inside the node. That is AV nodal re-entry tachycardia. Sometimes it will loop from the atria to ventricle. Every time when it loops, it produces a heartbeat. So the heartbeat will be much higher and that can produce tachycardia. So this is called as AV nodal re-entry tachycardia. This is AV re-entral tachycardia, and atrial fibrillation or multiple foci from here, everywhere produces atrial fibrillation. So all these things can produce tachycardia. So SVT is one important cause for supraventricular tachycardia, is one important cause for tachycardia. So whenever you have a patient who is having tachycardia, so first thing you have to see what is the rate? So we have learned in the previous classes 100 to 140 can be sinus tachycardia. Above 140 you can have various type of different causes for tachycardia, including SVT, VT, atrial fibrillation, all these things. So we have learned in the last classes by seeing the number of large squares in between the QRS complex, you can calculate the rate. Here 6 squares are there, so the rate will be 50. 300 by 6 will give 50. So you can calculate the rate, or the ECG machine or the monitor will simply tell what is the rate. Okay. So rate calculation is most important. Okay, that is the first step whenever you see a tachycardia. Second step is identify the cause for tachycardia. So there are multiple reasons for tachycardia. It can be due to drugs that we have learned. It can be due to hyperthyroidism. It can be due to fever. It can be due to sepsis. It can be due to myocarditis. Anything can produce tachycardia. So we have given all the causes here. So you have to find out what is the cause. That is the second step. Okay. Now we will see what is the third step. Because suppose the patient is having fever. Fever is there. Heart rate is 140. We simply reduce the fever by giving paracetamol. It may reach to 100 or 80. Okay. When you reduce the fever, if the heart rate persists like 140, 160, then there is some problem with the myocardium. Normally this viral myocarditis and all can sometimes produce tachycardia. So that is possible. Whatever it is, find out the reason why this patient is having tachycardia. That is very important. For example, atrial fibrillation is there. Already patient is having atrial fibrillation. Okay. So suddenly patient develops a cardiac failure. Then heart rate will become very fast, but still it will be regular. So atrial fibrillation is already there, mitral valve problem is there. All these things can produce tachycardia. Now third important step is whether this patient is stable or unstable. That is very important because I will show you the step here. So if the patient is unstable, then you directly go to this step and you give cardioversion. Okay. Now what are the unstable features? Patient is having altered behavior, altered low GCS, loss of consciousness, hypotension, hemodynamic instability, shock, pulmonary edema, poor perfusion. Okay. If any of these features are there, or suppose patient is having severe chest pain because of this tachyarrhythmia, then patient is unstable. Then your step here will be, you have to go for synchronized cardioversion. We will see afterwards what are these things. So this step you are seeing whether the patient is stable or unstable. Now, if unstable, then you have to cardiovert the patient. So sedate the patient, go for cardioversion. Okay. So cardioversion I am not discussing here because that's an entirely different topic. It takes lot of time. So you can start cardioverting the patient. Synchronized cardioversion, that is very important, that you learn when you learn about cardioversion. Okay. So if the patient is unstable, then go to this step. Now if the patient is stable, what is the next step? Now electrical cardioversion. So you can see here, switch on the machine. So this is a machine. Switch on the machine and select 50 to 100 joules or select any energy according to your protocol. If you are following ACLS protocol, in that you see how much shock you have to deliver and select the joules. Press the synchronizing button, that is very important. So if you are giving DC cardioversion, always synchronized button should be pressed, because when you are delivering the shock will be delivered here when you synchronize. If otherwise, any area shock can be delivered if you don't press the button. So synchronization is very important. I am not going to the details of synchronization now, but synchronized shock is important in DC cardioversion, whereas defibrillation we don't put that button. Now, if the patient is stable, what is the next step? Now, if the patient is stable, there are two important things. Is the QRS complex is wide more than 3 squares, 3 small squares, or narrow, less than 3 squares. Okay. So, if it is wide, then treatment is different. If it is narrow, then treatment is different. Okay. So, you can see here, this is a tachycardia. Patient is having narrow QRS complex. This is a irregular tachycardia, atrial fibrillation, but QRS complex is narrow. Here you have a patient with SVT with aberrancy, the QRS complex is wide. Here is you have a patient with probable VT, then you can see the QRS complex is wide. If the QRS complex is narrow, so you can see here QRS complex is narrow, then again actually you have two steps here. If it is narrow, regular, then that is actually SVT. If it is irregular, then it is atrial fibrillation. There is slight difference in treatment. SVT alone, you can go for vagal maneuvers, adenosine, beta blocker, and calcium channel blocker. If it is AF, better go for beta blocker, calcium channel blocker, no vagal maneuvers, no adenosine. Okay. Now, if it is wide, when the QRS complex is narrow QRS complex means it is originating from the SA node to AV node and it is going through the regular pathway. That's why you are getting a narrow QRS complex. If there is any aberrancy in the conduction system, for example RBBB, LBBB, or there is an accessory pathway, bundle of N, all these things you can see that the regular pathways are blocked. Regular pathways are blocked and the rhythm come from, in WPW syndrome, the rhythm come from the loop. Okay. So, the QRS complex can be wide. Okay. It can be SVT, but if you have RBBB or LBBB or WPW syndrome, even in SVT normally it is an narrow QRS complex, but even in SVT if you have RBBB, LBBB or WPW syndrome, the QRS complex can become wide. So sometimes it will be very difficult to identify what is the problem. So there is slight change from the actual treatment what we have given in narrow QRS complex. Narrow QRS complex you can definitely give beta blocker or calcium channel blocker. But remember, if you have a accessory pathway, because we are told three important reasons for wide QRS complex: RBBB, LBBB, WPW syndrome with SVT. There is one group, or VT as such, ventricular tachycardia. In patient who is having SVT with RBBB or LBBB, till here the conduction is normal, then it is going through the aberrant pathway. If you give beta blockers and all, it will only reduce the conduction here. Beta blocker, calcium channel blocker, it can reduce the conduction here. So SVT with RBBB or LBBB, beta blockers can be still used, calcium channel blockers can be still used. But in an accessory pathway, it is not like that. When it is going like this, if you are blocking the regular pathway, then the only available pathway is the accessory pathway. So sometimes patient can deteriorate. So in that type of wide complex tachycardia, if you don't know what is the actual reason for the tachycardia, better to go for a different drug, that is amiodarone. Amiodarone should be tried in such conditions. So you can see the doses here. I am not going to the doses here. Amiodarone first dose is 150 milligram over 10 minutes. Repeat as it needed, and it can be even given in VT. Okay, I have told that SVT with aberrancy like RBBB, LBBB, you can still give beta blocker or calcium channel blocker. Better to avoid these drugs in WPW syndrome. That's why any doctor who are not well trained, amiodarone will be a better choice. Amiodarone can be given here also, here also. So there is no issue, because amiodarone control the rate and it can have even control the rhythm. Now if it is SVT, that is narrow complex tachycardia, first always you try carotid massage, and if it is not coming, you give adenosine, then verapamil, diltiazem or calcium channel blockers. See the doses, I am not explaining all these things. Metoprolol or amiodarone. So amiodarone is there. Suppose you are not able to give all these things, you can still give amiodarone. There is no issue. Even in white complex, you can give amiodarone. Okay, because we don't know what is the reason for white complex, like SVT with RBB, SVT with RBB, SVT with white complex, SVT with WPW syndrome, or VT. We don't know what is the reason. Then also you can give amiodarone. That's why if QRS complex is white, amiodarone is a better choice. But if you have good knowledge about ECG, even you can still consider the other drugs which are given here, because if you have white complex tachycardia which is RBBB pattern, you can still give adenosine. There is no issue. But I am not going to the details of that. ACLS you have to train and you have to understand. Now narrow complex and wide complex, we have already told when you have a tachycardia, you have to see the QRS complex. Either it will be narrow or it will be wide. Narrow means regular narrow is SVT. Irregular narrow means it is atrial fibrillation mostly. But wide complex, it can be SVT with RBBB, LBBB, WPW syndrome or VT. So it is highly difficult to identify SVT and VT in emergency room by an ordinary doctor. But an experienced doctor with good knowledge in ECG can easily identify these two, and they can go accordingly, the drug can be selected according to the problem. That is possible, but it is difficult. Now there is a criteria you can read, that is Carbosa criteria. In that, one important step you have to follow. LBB, so that LBB with MI that can be used. It's Carbosa criteria. I am not telling. It is a slight deviation from the topic. This is for myocardial infarction. We will not discuss that now. But SVT alone, VT, SVT with RBBB. So what happens is, you know that RBB, yesterday we are told there is RSR dash pattern in V1, and if you have a tachycardia, there also you can follow this pattern. Whereas in VT, everything will be either positive or negative. This is called as concordance. Concordance means all the complexes in VT will be same. If you take V1, V2, V3, all it will be either positive or negative. But whereas in SVT with RBB, this will follow a pattern of RBB only. Okay. So each type of aberrancy, SVT with RBB or SVT with LBBB, it will vary from V1 to V6. It will vary. The morphology of ECG complex will vary. But whereas in VT, it will not vary. Okay. Now, I hope that you have understood wide complex tachycardia and narrow complex tachycardia. So, narrow complex is regular narrow complex is SVT. Irregular is F. But this can become wider if you have RBBB that has got a pattern of RSR dash pattern in V1, but it will be faster. Okay. So RBB can be like that. LBB in V5, V6 and all, it will be M pattern. WPW syndrome, again it will be wide, you will not be seeing the delta wave and all, but it will be wide. Whereas VT, it is all the leads V1 to V6, either positive or negative. So it will be highly difficult to identify between these two rhythms, SVT with aberrancy to VT, but that's why ACLS clearly say, if you don't know all these things, go for amiodarone. So that will be a good drug if the patient is stable. Now we will go for another important aspect of ECG reading, that is short PR interval. Short PR interval is a feature of WPW syndrome. So normally SA node to AV node conduction, AV node to bundle, the P will be there, QRS will be there, T will be there. But whereas here, what is happening? There is an accessory pathway somewhere here, so that will become faster than the original. Okay. So what happens is, initially the conduction will be normal, but once it enters to that loop, then it will be very fast. Each time it will be faster. So what happens is, P to QRS complex will be, normally it is, suppose it is like this, it will be shortened. Then it will go slowly, go up, then you get a wide QRS. This upsloping slurring is called as delta wave. Okay. So many patients, you can see when the patient's heart rate is very low, you can see all these things, but this can trigger a tachycardia. So that will produce, this is called as SVT with aberrant pathway, accessory pathway. So here if you use beta blockers, what happens is, not in all cases, this regular conduction may be blocked by your beta blocker, calcium channel blocker. The only available conduction system is this loop. That is much faster and patient will go to tachycardia. So for tachycardia you are giving beta blocker, but unfortunately it can even trigger high amount of heart rate. So that is WPW syndrome. There are two types, type A and type B. I am not going into the details of that. You can see here the difference in V1, what is type A, what is type B. Now what are the complications? Supraventricular tachycardia with aberrancy will produce a wide complex tachycardia. Okay. Patient can have syncope and death. Now we will see what are the causes for bradycardia. Physiological, when you are in sleep, you can have tachycardia. In trained athletes, you can see bradycardia. Hypothyroidism, cardiac blocks, raised ICP, obstructive jaundice, beta blockers, digoxin, diltiazem, verapamil, all these things you can have bradycardia. We will discuss about cardiac blocks. First degree heart block we have already learned, that is prolongation of PR interval. Normal PR interval is 3 to 5 small squares. If it is more than 5, you call it as first degree heart block. We will see that. PR prolongation is a feature of first degree heart block. So these patients will be normal, there will not be any clinical finding, but you try to avoid beta blockers or drugs which can prolong the conduction, that is diltiazem or verapamil. So here you can see AV block first degree, it is PR interval is prolonged, it is prolonged. Okay. So first degree heart block. Now first degree heart block shows here, you can see here, shows a prolongation of the PR interval. This is the P, this is the QRS complex. PR interval is this much. Normally it is only 3 to 5 squares. It is prolonged. So here you can see this is the P wave, this is a QRS complex, PR prolongation. Now causes of first degree heart block, it can be applicable to even to second degree and third degree heart blocks. Intrinsic AV node disease, enhanced vagal tones like severe pain, anxiety, fear, acute myocardial infarction, especially inferior wall MI, myocarditis, electrolyte disturbances, and some drugs. Now drugs, important drugs are calcium channel blockers and beta blockers. Digoxin can also produce first degree heart block. Now we will see second degree heart block. That is very important. First degree, there is no clinical relevance because it will not produce any clinical finding. You try to avoid drugs which can prolong the conduction, that is beta blockers or calcium channel blockers. Here, sudden drop of one QRS complex, that is second degree heart block. So you know that SNO2 AV node conduction occurs, AV node from to bundle, and suddenly one drop will be, one QRS complex will be dropped. So second degree, there are two types, type 1 and type 2, Mobitz type 1, Mobitz type 2. Mobitz type 1 is otherwise called as Wengebeck's phenomenon. There what is happening, you can see progressive prolongation of the PR interval and sudden drop of one QRS complex. It is like this. So first conduction is normal, second conduction is slightly delayed because of fatigue of the conduction system, third is still delayed, fourth lot of prolongation, fifth stop here, will not be conducted. So you don't get a QRS complex. This is called as Wengebeck's phenomenon. Whereas other one, conduction was normal in all the areas, suddenly one is dropped. Okay. But occasionally if you are not getting a QRS complex, it doesn't matter, it will not create much of problem for the patient. But if that comes very frequently, every second or third beat you are dropping means, then patient will become symptomatic. This is called as high grade second degree heart block, high grade second degree heart block. Okay. Now we will see what is third degree heart block. This is called as complete heart block. So here what you are seeing is P waves are coming regularly, QRS complex are also coming regularly, but there is no association between P and QRS complex. There is complete dissociation. So P waves are coming regularly, they are coming regularly. QRS is also coming regularly. But there is no association between P and QRS. That is because SNO2 AV node conduction occurs, that is blocked. Then AV node will not be functioning, so the junction or ventricle takeover function, that also will conduct. Okay. So this may be beating in 72 beats per minute, this may be beating in a rate of 40 beats per minute. Okay. So ultimately patient will develop bradycardia. You can see here heart rate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10. 300 by 10 is 30. So that is heart rate. This patient will become symptomatic. Now bradycardia algorithm, you have to see ACLS bradycardia algorithm is there. You can try atropine in most of the bradycardias, but you have seen that conduction system blockage, this may not work. If it is poisoning and all, toxicology, suppose it is OP poisoning and all, it will work. Suppose it is beta blocker induced bradycardia, calcium channel blocker induced bradycardia, then atropine may work. But if the patient is having hyperkalemic bradycardia, this atropine may not work. You have to go for the treatment for hyperkalemia. But ultimately, if the patient does, if the patient is not improving, you have to go for pacing. So pacing is a final answer for heart blocks. Many patients will end up in pacing if we don't treat properly. So we have discussed about tachycardia and bradycardia algorithms with possible treatment in emergency room. Thank you.